And I think we're good to go. So why don't we get started? I want to say hello and I want to welcome everyone to our very first orthopedic virtual tour at London Health Sciences Centre. We are so excited to have you all join us here today for this very special behind the scenes donor experience to learn more about the wonderful work being done within our orthopedics program. My name is Allison McCluskey, and I'm a Senior Development Officer here at London Health Sciences Foundation. And together with my colleagues who are also on our call today, and our wonderful team of orthopedic arthroplasty surgeons, together we are all very grateful that you've joined us, that you were interested in learning more, and we just really appreciate you taking time out of your afternoon for what promises to be a very interesting and a very informative tour. So first, I'd like to let you know a few things about the tour before we get started. First of all, right now, everyone is muted, and that's simply just to ensure a good sound quality throughout the presentation. The session is being recorded, and today's tour presentation is divided into 5 different sessions. So at the end of each one, there will be an opportunity for you to ask questions. That can be done one of 2 ways. So you can either raise your hand by clicking the hand at the bottom of your screen. That will signal to us that you have a question, and we'll go ahead and unmute you. Or you can simply click on the Q&A button at the bottom of your screen and you can type your question in. So you can feel free to type in your question anytime during the presentation and we can read out your question on your behalf. So thank you once again for joining us. We are very excited to share some of the exciting work being done here locally. And, thank you. Thank you to all of our donors. Thank you so much for your support. This is important work that's being done, and donors really, truly make all of the difference. So thank you for your passion. And with that, let's get started. So first, it's my pleasure to introduce Dr. Stephen McDonald. Dr. McDonald is the citywide chair chief of orthopedic surgery and the J.C. Kennedy professor and chairman of orthopedic surgery at Western University. He is nationally and internationally recognized for his research in hip and knee replacement surgery. He's published over 200 articles in the peer-reviewed literature and has presented and taught at over 400 meetings around the globe. He has served on the board and as president of several international organizations. He's also been involved in the design of hip and knee replacements that are in current clinical use. Dr. McDonald will be presenting on advances in joint replacement surgical care, and he is broadcasting live from his office at University Hospital. So over to you, Dr. McDonald.
Hi, Allison. Thanks for that kind introduction. I thought it would go on forever, but I guess I had to cut it short. No, thank you very much. And thank you for everybody joining. It should be fun this afternoon. We're all looking forward to it. We've worked away at our presentations. And so I'm going to screen share. Okay. Again, once again, good afternoon. My name is Steve McDonald, and I do have the pleasure of serving as a professor and chairman of orthopedic surgery in London, and also happen to be an arthroplasty surgeon. And yeah, for the next hour and a half, we're really going to be talking about an aspect of orthopedic surgery, and that is the arthroplasty team. And I'm going to start by bragging, but it's true. We use the word world-renowned a lot, but it truly is a world-renowned program. We have surgeons that visit around the world normally, not during COVID. And then on top of it, we have clinical fellows. So for those that don't know, a clinical fellow is someone who's completely finished their orthopedic residency. They're doing another year of training. And again, we have 7 a year from around the world who train with us for that extra bit of training. As a group, we've won countless international research awards, and we've designed hip and knee implants used now by millions of patients, once again, throughout the world. And I guess the first question you ask is, how did that happen? London's a great city. We all love living here, but how did that happen? And really, I'd say it happened because of vision. And it happened with the vision of these 2 gentlemen, Drs. Robert Bourne and Cecil Warbeck, who were the first 2 arthroplasty surgeons here, practiced together for their whole careers. And really created and then cascaded a vision outwards. And that vision was excellence in clinical care to start with, education, so residents and fellows, and then lastly, and very importantly, research. They then spun that vision, if you will, to the next generation. So it's myself in my younger years and Dr. McCaldon, who will be speaking in a few moments. So that's 21 years ago. That's what our arthroplasty group looked like. It looked like this, 2012. And these are the 7 arthroplasty surgeons that are here today. You're going to hear from 6 of them actually this afternoon. So Drs. Howard, Lanting, myself, and McCaldon, Noddy, Shemitz, and Vazzarelli. And together we make up the arthroplasty, the hip and knee team. As a group, we do over 2,000 joint replacements a year. It's a lot. And it's all done at University Hospital. And we do about 15% revisions or redos for whatever reason. And in case you're getting nervous, they're not all our own. In fact, most of them were sent to us from throughout the region. And we take on the most complex cases, really regionally, from Windsor to Owen Sound, all the way into around the Toronto region. And we say no to nobody. We take every patient and look after them. But to be successful, this is a team sport. And we have a huge research clinical team. So we have 2 parts to our program, which is clinical. So 1 PhD runs our clinical research, and then we have a full-time PhD that runs our basic science program. We have 3 research nurses. We have 4 nurse practitioners. So that's the individuals that you'll see if you come through the pre-admission clinic and who help look after the patients post-operatively. As I mentioned, 7 clinical fellows, and at any given time, 3 residents on our program. So again, that's what I looked like 25 years ago. A lot's changed in 25 years, not just me and my hair color. What's changed? Well, when I started in practice, it was routine for patients to stay 7, even longer days. And now we've done, I think, around 600 or 700 total joints as an outpatient, where they have their surgery and they go home later that same day. Before we tell patients, we hope to get 10 years out of your hip or knee. And now literally it's going to last a lifetime. Our patients have changed as well. So when we started in practice, the average BMI of our patients was 29 and now it's 34. So patients got heavier. And patients have also, their age has skewed. So we do younger patients now with confidence. And as the population gets older and actually healthier into older age, we do older patients as well. But in that time, we've improved our results and our outcomes and our patient experience. And if this was a live audience, I'd ask show of hands who knows someone with arthritis, and almost everybody would, because it's incredibly common. It's over 100 different conditions. Osteoarthritis, the most common, affects 1 in 10 adults. So this is a typical X-ray. So this is the femur, the thigh bone, tibia or shin bone, and this is the joint itself. And this space here you're seeing, that's sort of normal, that's cartilage, and there's no cartilage. That's bone-on-bone arthritis of the knee. And same thing for hip. So this hip is normal, so that's your thigh bone or your femur. The hip is a ball and socket joint. So there's the ball. You see that space is filled with cartilage. Again, that's normal. This side, that's bone on bone. So if you think of osteoarthritis as the most common, that's the one that most people will have. Wear and tear of the cartilage is part of the aging process, and it can be accelerated by various factors. And this is the typical arthritis you think of: daily pain and pain at night, limitations of activities, and sometimes deformity. And those that don't have arthritis or don't know people with it, it can be minimized. But if you're the one with it, it can be incredibly debilitating, particularly with significant disruption and really all of your activities of daily living, really decreasing the quality of life. One thing that has really changed, and we don't talk about it much, is just the demographics of our population. So at the turn of the last century, only 4% of the population was over the age of 65. With the advent of all sorts of improvements in medical care, it's estimated that by 2030, it'll be 22% of the population. So that change alone, just the sheer numbers of patients that are really in that age category for wear and tear arthritis. Currently, it's estimated that $485 billion a year are spent on management of osteoarthritis in both direct and indirect costs. That's in the US. But here's really the challenges when it comes to osteoarthritis of the hip and knee. While it'd be great to be able to prevent it or cure it or reverse the process or even halt the progression, those are all great goals. We just haven't achieved that yet. And so 50 or 100 years from now, perhaps, but right now we're still at the point where we get to the end of the road, we're left with really one choice, and that's to replace the joint. So joint replacement is arthroplasty. That's what the term we use for it, where damaged parts of the joint are replaced with metal and plastic. It's made to resemble the normal anatomy as much as possible. And US figures over 1 million hips and knees done per year. Canada is about 10% of that. And these are little depictions of the implants themselves and what they look like. Classic X-ray, both these knees have been replaced. So again, this is the bone up top. This is the metal piece here. And then the space that you're seeing, that's the plastic. And yes, it should set off airport alarms wherever you travel. So if we look at hip arthroplasty as an example, it's very successful. Over 95% last a lifetime, very high patient satisfaction. However, in the past, there was a problem. And it's depicted in these x-rays. So if you look at this x-ray, this socket has fallen right into the pelvis. This ball has worn through a big hole in the bone. It's all due to the same phenomenon, that the plastic was wearing out and failing. So here's a depiction of this plastic completely worn through. Again, another piece fragmented. And this is what we're dealing with. And so we would tell our patients, we hope to get 10 years or a little bit more out of this implant, but we could see a catastrophic failure. And then everything changed. About 20 years ago, there was an explosion in alternative bearings with a new type of plastic, as well as some other things that became popular for time, ceramic on ceramic and metal on metal. And while not all have turned out to be exactly the same in terms of outcomes, this, which seems innocuous enough, it's just a picture of the new plastic, completely changed a lot in arthroplasty. So what has your support done? Your support and the support of your predecessors? Well, it's made a significant impact through funding of our research. I already talked to you about that new plastic. Well, one of the very first publications that came out, and Dr. McCall was the lead author on this paper, was a randomized clinical trial is the best type of trial in any discipline in medicine. And that's where patients either receive the current standard or a new treatment, and they're randomized. So they're assigned to one group or the other, and then you follow the patients. And this was shown very early that this new plastic had 10 times less wear than the other plastic. I mean, that's a significant difference. Again, one of the first publications in the literature on it. And now we can tell most patients with confidence that their joint hopefully will last a lifetime, save for some other rare outcomes. What else has your support done? It's made a significant improvement in postoperative pain management. So when patients are asked what are their concerns following a hip and knee, their number one concern is often pain right after surgery. One option that was not explored previously is, well, what about if you locally infiltrate, in other words, inject around the hip and the knee with a long-acting freezing? Again, the first randomized clinical trial came out of London showing the efficacy, the effectiveness of doing that for our patients. It is now the standard of care around the world. And I'm giving examples of older studies just to show, the funding that we've received and the support we've received for over 20 years has made a difference in countless patients' lives over that period of time. And that you're going to hear in the next few talks what we're doing in 2021. But I think it's important to also understand what we've achieved to date. What else has your support done? Well, Canadians don't brag, so it's a good thing I'm Scottish, actually, so I will go ahead and do it. Because as I mentioned, London is one of the premier centers in the world for hip and knee replacements. And that idea of training orthopedic surgeons from around the world, here's a list of some of the places, not all even, but some of the countries that our fellows have come from, and then we send them off to go back to practice, and they train the next generation of surgeons in the most up-to-date techniques. We have a database of over 43,000 patients. In other words, when we collect data on our patients, both preoperatively and when they come to clinic postoperatively, we record all that, we keep it. And that allows us to track patients, follow them, their outcomes, and also report on those really for the rest of the world to understand trends and how implants are doing or any other questions we may ask. If and when we get to a point where we have to redo a hip or knee, we keep those implants in what's called the implant retrieval lab. We have one of the biggest in the world of over 5,000 implants. And once again, then we can study why implants have failed. And often you don't know what question to ask today, but by saving the implants, it allows us to ask questions tomorrow. So Dr. Lente, for example, and Dr. Howard have done a lot of fantastic work on implants that we kept and retrieved, and then were able to be studied later on. What else is your support? I mean, we have multiple ongoing research projects at any given time, and you're going to hear just about a few of them. Here's an example. Every year, Canadian Orthopedic Surgeon Group meets. We submit over 30 research papers for consideration at that meeting each and every year, by far and away the most than any center across the country. As mentioned, we're on the cutting edge of developing new implants with several of us working with industry partners. And we're on the cutting edge of developing new techniques. Robotics is coming down the pipeline, and you're going to hear about that this afternoon. And in 2021 and beyond, that's a very exciting and emerging field. But lastly, we never forget, it's the patients that are most important. The patients trump technology. And so we want to be very patient focused and understand any new technology, techniques, implants, how that improves ultimately the lives of our patients and the outcome for our patients. And so I want to personally thank you for taking 90 minutes out of your afternoon this afternoon to listen to our updates and our presentations. And again, thank you. And I'm happy to take any questions if you have any, other than if anybody's on the call on my waiting list, I can't do you any sooner at the moment. Thank you.
Thank you, Dr. McDonald. Does anyone have any questions? If you do, please use the raise hand button on the bottom or the Q&A chat function, and we'll go through your questions now. If there's something that you think about later, please feel free to put it into the Q&A chat, and we'll try and address it at the end if you don't have any current questions right now. Perfect. Well, I'll pass it over to Allison, and if there's any questions, we'll address them at the end. Thank you so much, Dr. McDonald.
Pleasure.
Thank you. Thank you so much. Thanks, Dr. McDonald. That was very fascinating. Thank you so much. And it's my pleasure now to introduce Dr. James Howard. Dr. Howard is a member of the Division of Orthopedic Surgery at LHSC, and he is an associate professor and the program director for the Orthopedic Residency Program at Western University. He is a current member of the Hip and Knee Society. Dr. Howard's clinical practice focuses on primary and revision total hip arthroplasty. So Dr. Howard, he will be presenting today to us, teaching and training the next generation, and he is broadcasting live from our orthopedic teaching room at University Hospital on the 9th floor. So welcome, Dr. Howard. Thank you so much for being here.
Well, thank you very much. So I'm just gonna get this all set here. Okay, so we're going to talk a little bit about teaching and training the next generation of orthopedic surgeons. And I'm going to take a little bit more of a step back from the arthroplasty unit itself and sort of tell you a little bit about the lay of the land in terms of teaching all of our trainees in orthopedics across the city and in the university. So this is our orthopedic family. This is a picture from our residence day. So that's one day a year where all of the residents present their research projects and we all come together. It's the highlight of our academic year, and this is the last time we were able to do it prior to COVID coming down. So we look forward to getting back to this in the future. And I want to talk to you about how we train this group of wonderful ladies and gentlemen to become surgeons. Now, our division was founded by Dr. Kennedy a number of years ago, and one of the things that he believed was in specializing as a surgeon, so that you were doing your research, you were doing your teaching, and your clinical practice in a certain area, and that is carried through in how we do our education here at Western in orthopedics, such that we have 6 different clinical teaching units spread across the city. So at University Hospital, where I work and where I'm broadcasting from today, we have our arthroplasty unit that was founded, as you heard, by Dr. Rohrbeck and Bourne, and we also have the sports medicine unit through the Fowler Kennedy Center. St. Joe's has our upper limb service at the Roth McFarlane Hand and Upper Limb Center. And our Victoria Hospital is our main trauma center, as well as where we concentrate all the spine work and the pediatric work at the dovetailed with the pediatric hospital. So spread across the city is our Western Orthopedic Surgery residents. So these are our current residents. We are one of the bigger programs across the country with 25 residents right now. There's only a few that are bigger across the country. And it's a 5-year program, so they would progress down these pictures to the bottom. We have the 4 gentlemen at the bottom who are currently studying like mad, hoping to pass their exam in a week or 2. So these form the majority of the trainees that we're going to take care of. But in addition, across the city, we have a number of fellows. The Arthroplasty unit, as Dr. McDonald touched on, has 7 fellows spread across our unit, and a number of the other units have fellows. Now, a fellow is somebody who's completed their medical training and has really come to one of our units for real subspecialty training in that area. So this is a spectrum of how people need to learn, and there's different approaches in terms of how you might help people to become the surgeon that they need and want to be. And I was thinking about putting this talk together. I was looking at what sorts of things have we done, or what are we changing in terms of operating room experience, our teaching facilities, as well as adding in simulation. So these are kind of the areas I wanted to touch on from an educational standpoint. So starting with operating room experience. So one of the principles that's always been in our program is that we want the residents to get in and do the cases early. So this is just an example of, on the right-hand side, Wale is one of our PGY1 residents last year, working with Jay, who is one of our new grads, doing a tibial nail. And we want to make sure he's getting in and getting his hands going as soon as we can to start to learn those technical skills. But one thing that has changed over time is looking at the educational model of how we do the training for the residents. And in the past, it's been a very time-based model, or a T-steeping model, meaning that if you put the resident in the program for the 5 years time and they bounce around long enough within that program, they should come out the end the way that you'd hope that they would come. And what we've been changing in training recently is going to more what's called a competency-based education initiative. And this is something that's across the entire of the country in terms of different programs. And we've really just started deploying this in orthopedics over in the last year. And it's something that really looks more at residents' abilities. It's more oriented to the outcome of how they're doing, and de-emphasizes the concept of time-based training, because some people will learn certain skills faster one way, and other people will learn different skills and in an easy way. It's much more learner-centered. The learner is supposed to be much more engaged, and the assessment is really driving the learning, meaning there's not the same recipe necessarily for all of the learners. And so this is an example. This is one of the goals and objectives for doing a total knee and total hip replacement. And it's broken down into very specific milestones or goals that we expect the trainees to be able to achieve. And so we were doing this in the past, but what really has changed in terms of we writing this down, we're clearly defining it for the trainees. And then we have new dashboards in terms of how we're assessing them and really doing it in much more real time, as opposed to spending 3 or 4 months and finally getting your final evaluation. We're really documenting how the resident and the trainee is learning in real time, and hopefully helping to direct them and develop that much quicker. So in terms of teaching facilities, things that we've been changing as we move forward with our training program, we're certainly trying to bring our facilities into the 21st century. And the real highlight of this couldn't have happened without the support of our donors, and that is the Orthopaedic teaching room. So these are some pictures that I took prior to the room that I'm sitting in being renovated. So we had a chalkboard that had some nursing stuff on it, and we would use it for teaching. You can see some of the lights in the roof were not really working. We're kind of working off one light, and the sticker on the inside of the door instructing us not to lock it, because we could actually lock it from the inside and the lock would stick. So with the support of generous support of our donors, we're really able to revamp this, and this has become the hub of our teaching at University Hospital. So this is a picture of the room I'm in right now. This was opened in June of 2018, and we really took this back to the studs and got a room that really allows us to do a number of different things. We've got behind me 2 high definition screens that we can either parallel the images or have multiple different feeds in terms of video feed and a PowerPoint feed on another one. At the far end of the room in the picture here, you can see a smart board, which will double as something we can draw on with dry erase markers, but also interactive smart board for teaching activities. The podium itself has a completely integrated computer stack that is accessible to the patient clinical record, as well as our local and our regional imaging. So we can pull an image from most of Southwestern Ontario to be used in teaching as part of our setup. And the entire room is set up for video conference capability. So in terms of being a Zoom or WebEx or using the OTN system, which runs across the entire province. We actually use the OTN system, the teaching on a weekly basis with our residents. They come to this room. We do a teleconference teaching session with our colleagues in Toronto who do tumor teaching and broadcast it here. And since we deployed that, it's now being done not only by us, but Master and Ottawa have joined on. So we've got 4 universities collaborating together in this being the hub of that activity here at UH. And without this room and the support of the donors, we really wouldn't have been able to do it in the format that we do it right now. So this has been a great step forward for our orthopedic education here. And the last thing I wanted to touch on was the simulation skills that we're trying to build in with our trainees to augment the learning that we're getting in the operating room. There's no question that learning in the operating room is valuable, but we want to make sure people have the opportunity to gain those skills in different ways, potentially in less of a high stress environment, such that when they get to the operating room, the learning can be even that more beneficial. So we've been, over the last number of years, particularly the last decade, we've added in a number of other activities. These are some pictures from what we call our orthopedic boot camp, which we bring all the residents together in the first month of July when the new trainees come in, and we go through a variety of things, including, these are some examples of doing some injections and aspirations on cadavers. On the right-hand side of your screen, we're practicing putting on a halo vest, which can be used in certain situations to stabilize C-spine fractures. We've got a number of labs here. These are samples for doing what we call a bone saw simulation lab. So these are prefabricated models that look like bone, and we can practice putting in screws into various bones, allowing us to get the residents to get the feedback of what that would feel like. On the bottom right, the residents are practicing some maneuvers there for reducing a dislocated hip, which happens quite regularly in Dr. McDonald's practice. I've never really had it happen to mine, but the residents do need to know when they're on with him. And in the upper right, that's a cadaveric experience lab where we're actually practicing arthroscopic skills here at University Hospital, so the residents can do that in a little bit of a less of a high stakes environment. So these are things we've all built in over the last 10 years, and where we're likely going with this is to add in virtual reality simulation, and this has really just started to come onto the scene recently, and it's something that I think we're going to be incorporating hopefully in the near future into our program. And so these are similar to anyone who's seen a video game system like a PlayStation 4 or 5 with a virtual reality headset. It's very similar in terms of how that would look, and what it allows on this quick clip, you can sort of see how it creates an environment on the computer that the user would be able to see what's going on and practice certain surgical skills as they go along with the activity. So those are some of the developments we've had across the city in terms of working with our trainees. And I thank all of you for taking the time today to join us, and I'm happy to take any questions. Thanks.
Thank you, Dr. Howard. If anyone has any questions, please use the raise hand or the Q&A chat function, and we can answer your questions now. Perfect. I'll pass it over to Allison, and if anyone has any questions, you can hop on the end and ask those questions.
Terrific. Wow. Well, thank you so much. Thank you, Dr. Howard. That was just fascinating, wonderful photo. So thank you so much. And up next, we have Drs. McCalden and Vassarelli. So Dr. Richard McCalden is a professor of surgery at Western University. Dr. McCalden has been in practice in London since 1994, where he is now the fellowship director of the Adult Reconstruction Unit at LHSC. Dr. McCalden is a member of multiple orthopedic associations, including the North American Hip and Knee Societies and the International Hip Society. And also we have Dr. Ted Vassarelli. So Dr. Vassarelli is an associate professor of surgery and head of the Arthroplasty Unit at LHSC. He specializes in primary and revision total hip and knee arthroplasty, and also has fellowship training in orthopedic trauma. In addition to clinical research, his research interests include healthcare economics and musculoskeletal infections. So together, Doctors McCaldon and Vassarelli will be broadcasting live from the the Rohraback-Born Joint Replacement Clinic at University Hospital. Dr. McCaldon will be presenting on the impact of clinical research to improve patient outcomes, and Dr. Vassarelli will be presenting on orthopedic infections. So with that, I will hand it over to you, Dr. McCaldon.
Thank you very much, Allison. You guys can hear me okay? I've got the mic on properly?
Yes.
Excellent, good. So I'm going to share my screen, and I've been given the task of talking about sort of how clinical research that we do leads to outcome improvement for patients. And I think it's, I could probably spend a few hours doing this, but I won't do that. I've got 10 minutes, but I think you'll see pretty quickly that our unit has made quite a big impact on the patients that we treat and the patients worldwide, quite honestly. I can't see myself here, but not that it matters a lot. There I go, now I can. So in fact, what I'm going to do is just quickly go through a few things that we've done here at our unit, and Dr. McDonald has actually set the stage quite nicely. So there's going to be a little bit of repetition, which I think is fine. And so why do we do clinical research? Well, the reason is that primarily kind of three things I could come up with, and I just got to get my screen going. There we go. We obviously want to contribute to our understanding of total joint replacement surgery. We want to develop new techniques and technology for joint replacement surgery, and Dr. McDonald's already outlined that. But really, at the end of the day, we really want to improve patient outcomes, and I think that's been one of the tenets of really why we're here. Our research team consists of really 7 orthopedic surgeons, 6 of which are speaking to you today. We have 3 full-time PhDs, and you'll see their names come up in some of the papers that I'm going to discuss. We have 3 to 4 full-time research coordinators who enroll patients, follow up patients, et cetera. And then of course we have fellows, residents, and medical students, all of which are part of our research team. And it really is a team. This is just an old picture of the 4 of us kind of about 20 something years ago. And you can see how Dr. Rohrbeck and Bourne look the same as they do then. And Dr. McDonald and I have changed immensely, as you can see. So the data collection here is a very important part of what we do. We have a very long-standing clinical database. We have a long-standing operative database. And we've also, as Steve alluded to, we have an implant retrieval lab that's been around for almost 20 years now. So if you're a patient, you understand where I'm coming from here. We all fill out these forms every time we see you, and you fill out these forms, and these are so-called patient-reported outcome measures, or PROMs, and we call them the blue sheets, which are now white, but you remember, if you're a patient, you know what I'm talking about. And we as doctors also have to fill them out. And this is all of this information then goes into our database, and that's allows us to basically report on things and basically make some conclusions about what is better and what is worse for patients. We also do in the operating room. So every single time we do a surgery, we basically fill out a form like this, which is then inputted into a computer. And we have what's called the stickers, where we know over the last 30 years, we know with absolute certainty every single implant that's gone into the thousands and thousands of patients that we've operated on. And what this leads to is a lot of productivity. And I would say at a low estimate, we publish between 20 to 30 peer-reviewed publications per year. We've done countless lectures and presentations at national meetings, all of us, of course, pre-COVID. We've won several hip and knee society awards. And if you look at our unit in total, including Dr. Bourne and Rohrbeck, there's probably 450, which is once again a small indication, a small estimate rather, of peer-reviewed publication. So this really tells you that we've put London on the map in terms of research for sure. So has this led to improved outcomes? I mean, absolutely. I'm going to just give you a few highlights. So Dr. McDonald already alluded to this study. This was one of the first sort of randomized controlled studies that I think really made a big difference, where we looked at this new plastic. And we basically took, right around the turn of the century, if you'd like, we basically took 100 patients, and in 50 of them we put a cross-link, or the new plastic, and 50 we put the conventional plastic, really not knowing what we're going to find. And they had the exact same operation other than the plastic that they got. And what we found was quite striking. These are the results of the Harris hip scores, which are all the blue sheets. We didn't find any difference at 5 years, and we didn't expect to. But what we did find, and you've already seen the slide, that after basically 2 years, there was a very clear difference in the amount of wear that was occurring in the patients in these two groups. And if we looked at this as a rate, at a wear rate, there was a very significant difference between these two materials. And this was highly statistically significant. And what this meant was that there's no question that this highly crossing material had become already the new standard polyethylene. So the next step, of course, was to try to figure out, did this lead then to clinical or patient benefit? And we did this by looking at, you can see the authors here, we looked at basically our patients now at 13 years following surgery who had received this. And we wanted to answer the question, did the patients that received this new material versus those that received the old material around the turn around the 2000 period of time, did that lead to clinical benefit for our patients? So we looked at a kind of a small group. These were all younger patients where we were more concerned. And the long and short of it is that they were completely identical, except that some of them received the new material and some of them received the old material because, of course, at the time we didn't know if there was going to be a benefit. And what we found that there was really quite a striking difference when we looked at these patients at 13 years. You can see in the conventional group that 14% of those patients had already undergone a new operation or revision surgery because their polyethylene had worn out, compared to 0% in the other group. 18% of the conventional group had signs of bone loss because of wear, compared to 0% again. And the wear rate was about 3 or 4 times more in the group, the conventional group. So there was a very striking difference. And if we look at what's called the survivorship curves, the red line there that you see is basically where it should be. That means that basically all of those patients continue to function well. And you can see that about the 10-year mark, what happened was those patients who had conventional polyethylene started to fall off, and some of them required surgery. And you can see the difference at 13 years where they have dropped off. And what this really means is that basically there's clear clinical benefit of this new material. And now this is, of course, the gold standard. And this has probably been the biggest change in my practice over the last 26, 27 years. The other area that we focused on, and Steve already alluded to this, is the idea of basically improving pain scores and pain around the time of surgery. And we were one of the first groups to really publish information in this regard. And this is just this kind of cocktail that we use currently, which is basically the most important component, which is ropivacaine, which is a long-acting anesthetic. And you can see that if we look at these bar graphs, you can see that at the very early postoperative times, the amount of pain that patients were experienced was quite different between the groups that had an injection versus those that did not. And similarly, the amount of narcotics that they required was very different in the very early postoperative period and the overall narcotics. And we know that that's important because we're trying to get patients away from narcotic as quickly as possible. There's good evidence that that's obviously in their best interest. So as a result of that study, the infiltration of local anesthetic has really become the standard of care for total joint replacements really around the world, quite honestly. Now we've taken it to the next step, and there's a lot of different authors here, but I think Dr. Howard was probably the main author here. And this was a blinded study comparing simply using injection to using what's called a motor sparing blockade. And what he showed here, what our group showed here, was that there was quite a difference in terms of the duration of anesthesia using this newer technique. And also the pain scores at rest in the early postoperative period of time and the pain scores with activity in the early postoperative period of time were much better in the motor sparing block group. So because of this, but at the same time, there was no difference in their quadriceps strength. So there was no downside to using this technique essentially. And because of this, these motor sparing blocks have really become, they've been adapted now as really the standard of care that we provide for our patients here at London Health Sciences Centre. So you already heard earlier that we're also doing some cost effectiveness and research related to the economics of total joint replacement. And Dr. Vassarelli has been sort of our lead guy here. And this is a paper that he's published recently. I won't go into the title because it's quite long, but we know that treating patients who are more obese, particularly over a BMI of 40, is more expensive for the healthcare system. But our question was, and because of this, in the United States in particular, that there's been a lot of criticism for treating patients who are heavy like this. And there's been the sort of the concept of a cutoff, which we think is sort of unethical because we know these patients do just as well, with the exception of having a slightly increased profile in terms of complication. So our hypothesis was really that these patients would indeed be more expensive to look after, but the additional expense would be justified because of the significant improvements in their quality of life. And I'm going to show you a slide. It's a little bit complicated, but really on this, the horizontal vector here, basically this is basically quality of life. So the higher you go this way, the better something is, and this is the cost. So the higher you go up here, the worse something is. So in simplest terms, basically, this is a very good intervention because it doesn't cost very much. It has a huge impact. And this is a bad intervention because it's very expensive and has very little impact. So if we look at where total hip lies, it's off the scale in terms of being good. It's way over to the right here. And this is all the standard patients, that are basically the least obese, and they do extremely well, very cost effective and very effective. But even morbidly obese patients are very, very effective in terms of the cost intervention, even though they do cost a bit more. And even our most obese patients, the intervention is extremely cost effective in spite of the fact that it does cost more. And there's these sort of lines here that you can see, which are called willingness to pay thresholds. And those are basically what is considered to be acceptable as a taxpayer, as a society to be able to pay for. And you can see that all these numbers, whether it be $50,000 or $25,000, all of our parameters are well below that. And if you compare this to cardiac interventions or kidney replacement, things of that nature, there's nothing better than really a total joint replacement, even in the setting of obesity. So there's no question that while the cost of treating these patients does cost more, it's been shown to be highly cost effective. And this, I think, has changed the way we think about, how we should be spending our healthcare dollars. And last, certainly but not least, this is sort of Dr. Lanting, some of his work, along with Dr. Teeter, who's one of our PhDs, and they've done a lot of work looking at various things. And this is just one of many, many studies that he's published. And this is looking at the direct anterior approach, which he's been the champion of here, and looking at two different stems to try to decide, is there a difference, or is there maybe an advantage of using one stem design versus the other? And these are the two stems that are on the market. One has what's called a collar, which is this little thing here, versus a collarless stem. And basically the thinking was we wanted to see if there's a benefit to one versus the other. They use some very sophisticated imaging techniques called RSA, which we have a lab here that's dedicated to that. And in fact, Dr. Naughty was the one who sort of got it off the ground. And it's sort of a very sophisticated way of looking at migration. And we're one of a very small number of units across the world that actually has this technology. But basically what they did is they looked at this technology, or used this technology, looked at migration. They also used these sort of Fitbit activity trackers to look at the activity that these patients were doing in the very early postoperative period. And what they found was interesting enough that there was a difference between these two stem designs, where the collared stem actually moved a lot less initially in the first couple of weeks following surgery. But after 2 weeks, there was really no difference between these two stem designs. And they also showed that in terms of activity, there was a little bit higher activity level in the collared stem, which may relate to the fact that their stems were moving a little less in the very early postoperative period of time. But the overall function was actually similar. And certainly when they looked at the patients out at 12 months, there was really no difference. But I think that what's that led to the kind of conclusion that really this less migration and maybe the faster return to function for the collared stem was really advantageous. And I think in Dr. Lanting's practice, this has kind of become the implant of choice for his direct anterior approach patients. So why we've been so successful at clinical research in this unit? Well, we have a great team. There's no question that it's a team effort, and I think you've heard that many times already. We're all dedicated doing research and improving patient outcomes. And lastly, but certainly not leastly, I think there's no question we have the support of our amazing donors, some of which are listening today. And I really appreciate your time, and thank you very much for your attention today. Any questions, I'm happy to answer. Thank you. And with that, I will unshare my screen if I can here. Maybe I can't. Why can't I? Stop share. There we go. I have to be able to read. Okay, any questions, anyone? That's either a good sign or a bad sign. So I'm going to take myself off and let Dr. Vassarelli take over.
Sure.
Okay. Thank you very much, Rich. And I'd like to thank everyone for taking time out of your schedule today to listen to our group. And hopefully this afternoon gives you a flavor of the type of work we're able to accomplish as a group. And we're certainly extremely fortunate to work in such a collegial environment. And you can see how that's driven us to be such a productive team. One of the things I'm going to focus on today is just talk to you a little bit about some of the research and basic science research we've been doing in the area of orthopedic infections, which in my mind, and I think arguably, is the single most important unresolved issue in orthopedic surgery. So these are numbers taken from the Canadian Joint Replacement Registry. And when we look at sort of the trends over the last 5 years, we see that in 2018, 2019, approximately 140,000 hip and knee replacements were performed in Canada, which is about a 20% increase over the past 5 years. Now, with that increasing primary volume, we do know that there's a percentage of these hips and knees that go on to revision surgery. And looking at the past 10 years in Canada, at 10 years, about 4.5% of hip and knee replacements are revised. When we consider the reason for revision, the top 3 reasons are infection, aseptic loosening, and instability, with infection accounting for nearly 1/3 of all revisions in Canada. And this is true across most national registries, so not unique to us. So we've seen that with increasing volumes, and there's a concomitant increase in revisions, which are largely attributable to infections, significant effort has been made to solve the problem of infection, but as noted here in the Second International Consensus Meeting on Musculoskeletal Infections, which we've participated in, infection research is a priority. And to quote the group, musculoskeletal infections remain the bane of orthopedic surgery and result in grievous illness and inordinate costs that threaten healthcare systems. Prevention, diagnosis, and treatment has remained largely unchanged over the past 50 years. So in the US, we know that orthopedic infections are estimated to cost about $2 billion annually. To highlight some of the costing work we've done around infections, we look to provide a Canadian context. So the first study that we carried out in this area was looking at our primary hip replacements and comparing those to our infected hip replacements, which required a 2-stage revision. So in this first series, we took 50 consecutive cases and compared them to 50 septic revisions. And really, as a take home here, we found that there's a 5-fold increase to treat an infection when compared to primary total hip. The revision costs for a single patient were over $38,000 compared to approximately $6,700 for primary. The main cost drivers in this situation were costs associated with a longer length of stay over the course of treatment, which was 26.5 days compared to 2 days, as well as the implant costs, where the revision implants cost significantly more than primaries. Now, we carried out a similar study comparing our total knee arthroplasties and found very similar findings. Here too, there was a 5-fold increase in the cost to treat infected total knees compared to primary surgery. And the costs here were approximately $35,000 for revision compared to $6,800 for a primary total knee. So we can see that even with a very small percentage of cases that become infected, there's not only very significant patient morbidity and mortality associated with it, but there's also significant cost to the healthcare system. Now, as mentioned, as a whole worldwide, we've failed to advance our ability to prevent, diagnose, and treat infections. Here at Western, we're very fortunate to have developed strong research relationships with world experts in basic science. And over the past 3 years, we've collaborated jointly supervising multiple graduate students working in this area. And there's several different active projects we'll briefly touch on, just to give you a sense as to the type of work we're working on and what future directions we're headed in. So here's an example of a paper we published just a couple months ago. But staph species are bacteria implicated in about 50% of periprosthetic joint infections. So with the Heinrich's lab, who again are world experts in the area, we've been able to collaborate and start to apply their rodent models and look at the impact on orthopedic infections. So really what we sought to first do is look at the behavior of Staph aureus and synovial fluid and create an animal model to study periprosthetic joint infections and really look at what factors is it about bacterial growth and how those are impacted by the synovial fluid. Now, this really was a series of experiments that will sort of boil down to in the end, our ability to identify the component regulatory system in Staph aureus that allows it to survive in the presence of synovial fluid. Now, synovial fluid in and of itself is bactericidal, but we do know that bacteria can thrive in it. So it becomes a matter of trying to figure out what elements is it about the bacteria or substrates within synovial fluid that allows that to happen. So by identifying the pathways that the bacteria is metabolizing, our hope is to be able to generate therapies that we can look to modify and create more effective clinical therapies to address infection or more importantly, prevent infection in the first place from happening. Now, one of the most difficult areas to overcome bacterial defenses is a biofilm, which is a protective coating that they form on orthopedic implants that prevent antibiotics and body defenses from attacking the bacteria. So one of the ways we can potentially improve the ability to retain implants during an infection is having the ability to disrupt a biofilm. So one of the concepts that you can look at to do this is by heating metals. So in the series of experiments here, what we did is we took stainless steel and titanium washers, which are common metals used in orthopedic implants, and with and without the presence of antibiotics, we were able to show A, that we were able to create a biofilm on the metals, and B, in various experimental conditions, show that we're able to generate disruption of the biofilm with in vitro non-contact heating of these metals. Once again, although right now at the basic science stage, the hope is that we'll be able to apply this in the clinical scenario down the road. Now, the other question or other area that we've been looking at are implant materials. And we know that there are currently materials and material coatings that can inhibit bacterial survival. We currently have a master's student working on a series of experiments here. Based on previous work, we do know that copper is bactericidal. And so we've sought out to evaluate the effect of copper on Staph aureus and synovial fluid and determine the minimum inhibitory concentrations that we can apply to kill bacteria in this scenario. And once again, we've been able to show that at 24 hours, both sensitive as well as resistant strains of Staph aureus show increased killing in the presence of copper. And our future work will be to look at the effect of adding copper to implants and see whether we can generate the same results. So as mentioned, taking the example of copper, for instance, as one therapeutic option to kill bacteria, we can test the hypothesis with an animal model or an animal implant model of infection that's been created. So in combination with another lab and some of the work that Dr. Nadi has done with them, we've been able to use 3D printing to create what you see here are hip replacements for a rodent model. Now, these are titanium alloy hip replacements, which are sized based on anatomic measurements taken of rat femora with micro CT scanning. And you can see the scale of the implants here. Now, what this allows us to do is, we'll get that video playing, is you can see a rat here that's implanted with the hip replacement on a radiolucent treadmill. And this is at 12 weeks post-implantation. So it's an area that I'm extremely excited about, that we finally have the technology available as well as the expertise to carry out some of this cutting edge research. Having the ability to 3D implant or 3D imprint and then implant these. We also have the availability of bioluminescent bacterial species. So really our next steps will be to see what we can do in terms of changing the microenvironment around these implants to make them less conducive to bacterial growth, to hopefully prevent infection in the first place, but really examine that if an infection does happen, what therapies can we implement to eradicate the infection while retaining the implant and reduce some of those costs and morbidity associated with going through multiple staged revisions. So I hope that gives you a sense of some of the areas that we're working on. It truly is exciting that we have a world-class team of researchers working together on really the most pressing topic that we're faced with as orthopedic surgeons. And there truly is a significant potential for impact on improving patient lives through improved outcomes, as well as generating healthcare savings by modifying and improving how we deal with this challenging clinical problem. So I guess we'll open it up for any questions for Dr. McCalden or myself.
Perfect. Just gonna see If anyone has any questions, please raise your hand or use the chat function. If not, we'll answer questions that come up after the talks at the end of the presentation. So I'll turn it back over to Allison.
Thank you so much. Thank you, Dr. Vassarelli. Thank you, Dr. McCaldon. That was fascinating. Thank you so much. Next up, we have Dr. Brent Lantine. Dr. Brent Lantine is joining us. Just gonna see here. I'll start with, there's Dr. Lantine, welcome. Dr. Lantine is a hip and knee replacement orthopedic surgeon. He was first a mechanical engineer and is excited to research enhanced recovery, surgical technique and innovations, as well as the biomechanics of hip and knee replacements. He is passionate about research to improve patient outcomes. So Dr. Lantine is presenting today on enhancing patient care through innovative imaging, engineering, and orthopedic robotics. And he is presenting live from the Orthopedic Joint Retrieval Lab at University Hospital. So welcome, Dr. Lantine, and I'll hand it over to you.
Hello, everybody. It's super exciting to get to talk to you all today. I'm hoping this to be interactive if you'd like, or I can monologue, whichever you would prefer, but please feel free to jump on the chat with any questions or have your hand up, whichever you prefer. What I have in my hands here is just a standard hip replacement. You can see the femoral component here and the femoral head here, and you can see how there's a junction there. And then the aspect that goes in the pelvis, you can see that here, that inserts right into the pelvis, ingrows there, and the two articulate like so. That's a pretty standard hip replacement. We have one of two facilities in Canada that has a retrieval lab. And here's just an example. I'm just pulling one out of the recently retrieved implant. And I beg your apologies if you find this gross in any which way. If you'd like to avert your eyes, feel free to. But here's a standard retrieved implant. And you guys might be asking, why would you keep that nasty looking implant and examine it when you have the brand new beautiful version right beside it? What's the purpose of this nasty old implant? And isn't it a bit morbid? Well, great questions. The reason that we find it so exciting and stimulating to have these retrieved implants is that we can learn so much from them. We link our retrieval lab, and as you can see, we have literally hundreds and thousands of boxes of implants, and we link all these implants to our database and to our other information gained from our information sources that Dr. McCaldon and Dr. McDonald and Dr. Howard have talked about. And we link the patient characteristics, patient demographics, to what we know about this implant, and we take it from the retrieval lab, and we can having an understanding of our brand new implant, we can go through the retrieval lab and pull out every single one of its used siblings, so to speak, and examine how they failed. Or we can learn the characteristics of that implant, and that can lead to some phenomenally exciting outcomes. Now, for example, this is just another one, I'm just pulling it off the shelf here. You can see that there's another similar implant, and we've done a lot of research looking at this aspect of it, and that's called the trunnion. And by learning the characteristics of this implant and the characteristics of that trunnion, and this is an example of a large head metal on metal, we can learn a lot from that. And if you recall on CBC, there's been at least 2 or 3 episodes in the very recent years where they dedicated a lot of time and energy looking at implants just like the one I showed you and their longevity. Only we in London and centers like us can answer the why they failed, not just that they did, but the why. So we do that by bringing this implant over and assessing it visually, doing advanced imaging of it, and doing things with the collaborating with our engineering partners to look at the mechanical properties and do finite element analysis or other advanced computer simulations of the implant and why they might fail. Now, that's all very exciting. And we've had a number of high impact research presentations on that to inform us on not only why this specific implant may have failed, but also to understand how we can best serve patients that have similar designs. Now, I'm not characterizing this implant as a faulty one. I'm just using it as an example that why this implant, that we can look at why this implant failed and follow our patients that have similar implants more comprehensively and with more thoughtfulness. Thankfully, I'm very pleased to see a little question pop up already saying, do we work with vendors on failure analysis? And there's two aspects to that, and that's a very insightful question. And yes and no. So yes, in that we, when we have important data, we release it to the vendors and say, hey, this is what we're finding, and we publish it in reputable journals so that they can be released to other orthopedic surgeons. But also, we need to understand that we need to stay completely separate. So we are independent, and we have a clinical aspect, a clinical understanding that we need to stay separate from the vendors, and that's our strength, is that we can have a very thoughtful response, and we have a responsibility to the public and to you as our patients to be independently assessing, thoughtfully analyzing current products. We have been involved with an implant that's been recalled, and we provided a very unique and independent assessment as why that implant failed, and to provide information for those patients as well as to the extended community as to how we can better serve future patients. Now, one other thing we can do, and I'm just going to look at, let's see here. I hope you don't mind me coming in and out of the screen. I'm just looking for examples. This is a total knee replacement. And if you look really closely at this surface, you can see, oh, it's not coming through on the camera. You can see there's pitting in here, pitting of the polyethylene. And this polyethylene has some wear properties. And that's really interesting. And what we do is, by understanding our past, and this is very true in history, in the liberal arts world, but also even more true for us as physicians, that by understanding our past, we can look forward into our future. So because we have such a comprehensive research environment we get to work with, we can go to Retrieval Lab, and we've done this for this specific question, is look at an implant or failed, or not necessarily failed, but a retrieved for whatever reason implant, get a story from it, understand it, do a thorough assessment of it, then link it to our patient demographics that we have one of the oldest in North America database, link all that information and come up with conclusions. And Dr. Nadi is going to go over how that's important. Well, based on our history, based on our Retrieval Lab information here, based on our database, based on our advanced imaging, we can create an understanding of what each unique patient potentially can do best with, and what is their worst environment. And with the operative technologies that Dr. Nadi is going to describe, such as robotics, such as navigation, we can take the next step. And we can identify for patients just like this that had this implant, we can identify the right implant, the right alignment, the right surgical technique, and to individualize to get the best care for that patient. And that's part of why we're so excited to work with you, and that we can serve our patients, that we can give the best care we can. And that's unique to what we can do here at LHSC through the donations of our supporting community and through their interaction with us, so that we can take our next step. And our next step is continued excellence in patient care, continued excellence in research, and also perhaps in the very near future, we can do individualized patient care with the precision, with the sort of techniques that Dr. Nadi will outline in our next session. Is there any other questions or thoughts as I'm coming? I see that I have 3 minutes to go, and I'm sure Dr. Nadi is still getting ready. So any other additional questions? I'm not seeing anybody else come up, but we do, and just to highlight that here we see all the retrieved implants for knees. On the other side, we have shelf after shelf after shelf of knees, hips, and we do have an accurate assessment of all of these to leverage that knowledge to our current and future patients. Thank you very much, and I look forward to any questions if there is.
Thank you so much, Dr. Lanting. There's no questions currently in the chat, but we'll let you know at the end if there's any additional questions. Oh, sorry.
There's one question
There's
here.
one question.
Yeah, so metal and metal hip replacements, and I think they have been discussed in a negative context in literature, but that's not necessary. I think we need to be specific about what design, and that's what design, what characteristics. What implants are being currently used, and I'm showing you right here, is a pretty modern example of a ceramic head and a polyethylene liner. This could be metal, this could be ceramic. That question is an interplay of a variety of factors. But pretty commonly, especially here at LHSC, is a polyethylene liner. This is a highly cross-linked polyethylene, and we always say plastic as if plastic. But this is an advancement that was, and I think all of us surgeons would agree, that was a substantial step forward for us as an arthroplasty community. This is highly cross-linked polyethylene and very commonly used with a cementless backed metal cup and a cementless stem with a ceramic or metal head. Those would be the current materials being used. Any other questions? Great questions.
Hi, Dr. Lanting, there was a new question. If you had unlimited funds, what would your biggest need be for ongoing research?
Oh boy, it's like asking a small child to go into Toys R Us and pick out what is the main thing to work in. I think I would like to individualize that discussion with the person that has that question, because everybody has their own passion, and I think we as a group would like to respond to that unique passion, whether that's in teaching or whether that's in a retrieval assessment, or whether that's in hardware, or whether that's in programs. I think currently some of our biggest push is toward surgical innovation in terms of potentially robotics, or it's perhaps, if you have passion for that, we could, in collaboration with Dr. Vazzarelli, you could collaborate to lead our group toward more infection type research. Or perhaps it's in advanced imaging. We have some needs in there with respect to low dose 3D imaging of your entire body in a physiologic position. I'm not answering your question, but there is so many opportunities and so much potential. I think it's an individual choice, and I think my individual interest might lead more toward robotics and further interest around improving our surgical individualized plan for patients. But that's my specific passion, and I think that might be, Dr. Vazzarelli might say he has and I believe he would have a very specific infection-related area to direct in. But I think often we find an area that can be meaningful for you, as well as meaningful for us, and in an area that will mutually benefit surgical innovation as well as infection.
Thank you so much, Dr. Lanting. If there's any additional questions, please do add them back into the chat and we'll address them all at the end of the presentation. Thank you.
Thank you so much, Dr. Lanting. Thank you. These have been wonderful questions. Thank you so much. Excellent presentation. Up next, we have our final and last presenter, We have Dr. Douglas Naughty presenting. Dr. Naughty subspecializes in complex primary and revision hip and knee replacement surgery. His clinical practice also includes knee arthroplasty and hip preservation surgery, including hip arthroscopy. His research interests are in the evaluation of implant fixation and wear with advanced imaging modalities. Dr. Naughty has published over 120 peer-reviewed articles and 10 book chapters. He's an active member of both the hip and knee societies and has been appointed to full professor in the Department of Surgery Orthopedics. Welcome, Dr. Naughty. Dr. Naughty today will be presenting on emerging technologies, and he is broadcasting live from the OR at University Hospital. So thank you, Dr. Naughty. I'll hand it over to you.
Perfect. Thanks, Allison. I just want to make sure that my video and microphone are working. Can someone give me a thumbs up? Or
yes, everything's
seems
working.
to be okay. Everybody can hear me all right?
Yes.
Perfect. So just as the last part of our tour, I thought I'd bring you into the operating room. So at University Hospital, we have 17 ORs, 16 of which are operational on a daily basis, and 5 of those are dedicated to orthopedic surgery. In terms of joint replacement, on a typical day when we're not in the midst of a global pandemic, we operationalize 3 or 4 of those 16 ORs to do joint replacement surgery. So we've got a very large footprint in the operating room and a very, should I say, powerful presence in the OR. Now, 3 of the arthroplasty rooms where we do joint replacements are equipped with laminar flow. So I don't know if you guys can sort of see me. I'm in OR 15 right now. And you can see this plexiglass that surrounds the operating room, and there's lights that are on top. So laminar flow is very, what it does is it changes over the air circulation at a very rapid pace. And that is thought to reduce the infection risk. And as it turns out, it's probably the safest circulation to use in terms of whether we're managing someone with potential COVID, because the air circulation turns over at such a high rate, it actually is protective for us. So we're very fortunate that we were able to use these laminar flow rooms for infection purposes and during this pandemic. So I'm just going to adjust my screen here a little bit, and I kind of want to take you through a little bit of a setup. I've sort of done a mock setup here of a sawbones model of a knee replacement. So when we're in the OR, we would have a patient lying supine on the table with their knee bent, and we would be doing our operation. This particular sawbones model is using some emerging technologies, which I'm going to get to. And I'd just like to preface that by saying that these emerging technologies are only possible with the generous donations that we've received through the LHSC Foundation. And without them, it would really be impossible for us to bring them in. But with them, it really brings us to the forefront of joint replacement innovation and research, not only in Canada, but across North America. And I think that's been touched on with many of the other speakers, that we really strive on being the best and having, the ability to prove that new technologies work or don't. And that's the part where the research component comes in, where we're able to use these technologies, but not only use them, but study them and make sure that they're safe and that they're designed to do what they want to do. So I'm gonna just briefly show you a couple of these. Pardon my screen. I've got my computer kind of on a mobile Mayo stand here. I'm going to walk around and hopefully you can still hear me. So this is a navigation unit. So this is what we would do for hip replacement surgery or hip resurfacing surgery. And effectively what it does is at the time of surgery, we would put a temporary array into the bone when we're doing the hip replacement. And then it is read by this optical tracking device, which allows us to reference certain landmarks at the time of surgery. And this allows us to optimize the position of the implants that we want to put in, as well as create the best soft tissue envelope to prevent instability or problems. And then probably most importantly, it allows us to be bang on in terms of restoring leg length or offset so that the patient, has really an implant that matches their native hip or their other side. So that's a navigation unit. The future of orthopedics is without a doubt robotics. And I think all of the implant companies have a robot available for commercial use. Now there's different types of robots. There's robots that require imaging beforehand, such as a CT or MRI of the patient, and then that's registered into the machine. And then the surgery's taken care of by the surgeon using proprietary software, and then the robot is instructed to perform that under obvious safe checks and check ramps. There's other devices though that are fixed into one room and are immobile and are not able to be transported between room to room. So it sort of confines things to, if you want to use that particular robot, then you have to use that particular operating room. But there's also mobile robotic units, and this is just one of them kind of in the background here. I'm going to walk around and sort of show you. Hopefully you can sort of see this. So this is a mobile robotic unit. And so this can be taken from one OR to the next OR. It can be taken outside the hospital to do surgery at a surgery center, and it's very versatile. And it's got a knee replacement platform on it right now, but there's developments to use it for hip replacement surgery as well. And the idea here is that it also uses an optical tracking system, which again registers onto arrays that are put onto the patient temporarily at the time of surgery. And then the surgery is planned based on digitizing different parts of the knee. So we would take a probe, for instance, and we would register where we want the implant to sit, and so we can determine the size, the rotation, the depth of the cut, etc. And then what happens with this particular system is that it allows us to prepare the bone with either a burr or with creation of lug holes, which allow us to put our own cutting jigs on in the desired position. Now I've just set this up. This is a burr that I don't know if you can see that, but I think you can appreciate it. And if I try and move into the screen, you'll see on the back screen there's white and there's green and there's purple. And so I've registered this so that I don't want to basically take away anything that's white. So if I put the burr on and go forward and I touch anything that's white, it won't cut it. But it'll allow me, if I touch the area that's purple, to cut through that area. If you can see here, I'm going to just cut a little bit deeper. And what's really impressive with this is that the robot will prevent me from going too deep. So if I really want to try and push this and go really deep, it'll stop me. So it allows me to prepare this surface. Essentially with the burr, I can take away the bone that I want to take away, but I'm very safe in terms of not going too deep and just getting down to the prepared surface. So this is just an example of one of the technologies. I'm just going to walk around and show you. If I wanted to see a little bit of a different angle, I just touch the screen, not when I'm obviously sterile in the OR, but we can have someone do that from the side, and I can move up or I can move down, I can move to the side. And so really it allows me to prepare the bone very safely and very accurately. And this is just an example of one of our handheld robotic devices that we have here. And the goal obviously would be to have multiple implant companies with their different devices, and then we could do a head-to-head comparison. So on that note, I just wanted to thank everybody for their time this evening. It's really, I've been able to kind of follow things along as I've been setting up here, And it's really just impressive to see the different areas. And I'm very proud to be part of this unit. And I wanted to thank you for spending the time with us this evening. Are there any questions?
Thank you so much, Dr. Naughty. We did get one question asking what company makes the particular product that you were demonstrating right now.
So each of these products is so one is from BrainLab, the navigation platform. It was its own company, and then it was purchased by an implant company. This particular robot goes by the trade name of Corey, and was purchased by Smith and Nephew. But
Wonderful.
there's many different implant companies, and each of them have their own different type of robotic platform.
Perfect. Thank you so much. If anyone has any additional questions, please do put them into the chat or use the raise your hand function. Just wait a moment here. Perfect. I'd like to thank you so much. I'd like to turn it back over to Allison now for closing remarks.
Terrific. Oh my gosh. Thank you so much, Dr. Naughty. That was fascinating. So thank you for bringing us into the OR and showing us this beautiful new technology. If there are no questions, this is the conclusion of our virtual tour. And I want to take this opportunity to sincerely thank our incredible team of orthopedic surgeons. Dr. McDonald, thank you so much. Dr. Howard, Dr. McCalden, Dr. Vassarelli, Dr. Lantine, and Dr. Naughty. Your presentations were, we hope that everyone found the presentations inspiring and informative. So thank you all for your time. And then really, truly, I want to take this opportunity to thank all of you for joining us today. Thank you to our donors. This incredible research, this innovation, everything that helps support all of this groundbreaking, world-class patient care cannot be done without donor support. So we are so grateful. Thank you so much. Dr. McDonald, I'm not sure if you wanted to add in a couple closing remarks.
Well, first, Allison, I wanted to thank you and the foundation. I mean, you spearheaded this. You did a tremendous job with it. You made us all look good, which can be a full-time job for people. So I think it worked seamlessly. And I know these things don't happen without a ton of work behind the scenes. So on behalf of us, the surgeons, I wanted to thank you, Shannon, really everybody, Justin involved with this afternoon. So thank you. And I guess I'll leave it on the final note that, it's our distinct pleasure actually to do the jobs we do, the work we do. The patients, by and large, have fantastic outcomes. We take people debilitated and, in a few short weeks or months, give them back their quality of life. And that's what it's all about. And so you've heard a lot of presentations all geared towards the same thing. And that's all of us are working the same direction to make that patient experience better, to make the outcomes even better than they are tomorrow, than they are today. And we look at partnership with grateful patients and those that are much like yourselves on this afternoon as an integral part to our success. As I mentioned in my talk, it is a team sport, and you're integral and a very important part of that team. So again, thank you for this afternoon. This was a lot of fun. I think it was actually easier to do it virtually than to try and get everybody to walk around University Hospital, quite frankly. So I think it's very successful. So thank you, Allison, and thank you, everybody.
Thank you. Thanks, Dr. McDonald. So we wish everybody a wonderful afternoon. Please stay safe, stay well, and hopefully we can all be in person again one day soon. So thank you and have a wonderful evening.